our faculty, Rekha, Nisha, and all the participants who have registered for today's the Foxy WHO program on respectful abortion care. They have taken out their precious time to join. RAC Foxy WHO has joined hands with the Ministry of Health, and it is a women-centered program to provide confidentiality, dignity, autonomy, and justice to the women. India has taken the lead to join the MTP Act way back 1971, but after 50 years, we are still having the unsafe abortion as the third common cause of the MMR. So it was decided that as we had the respectful maternity care, the WHO program which is going on, they have decided that we should have the respectful abortion care, and also make all the participants, all the society members, all the Foxy members, to enlighten them with the Foxy Amendment, the MTP Amendment Act 2021. So it was a long journey. The whole process of this Amendment Act started in the January 2020, and finally we had the Gazette in the October 2021. It took nearly 2 years. So one can understand how much effort, and I know Ajay and Foxy, our president Shanta Kumari ji, and the whole team of the MOHFW and the WHO team has worked hard to get this Amendment Act, MTP Amendment Act. So to the safety and dignity, equity, confidentiality are the integral part of this program, respectful abortion care. So I just say that respect begets respect. And this amendment will also cover and help in fulfilling the SDGs 3.1, 3.7, and 5.6. I invite Chandraji, who is, I have grown to see that whole postpartum department of Queen Mary's Hospital, King George Medical University, on the shoulders of Dr. Chandravati, who is also our patron. So I invite Chandraji to give us a blessing. So this program is going to be a very successful program. So we need your blessing, Chandraji.
Thank you, Yashodhara. And it's a pleasure to be here today, because medical termination of pregnancy had been very, very close to me. Not that I would offer this thing to each and everyone who is wanting contraception, but at the same time, if the situation has come and if it is within the rules, I would like to each woman to have a safe abortion with dignity, with the privacy she wants, and give our services to the best. At times, we start judging couples or even women when they come seek abortion on our grounds, on our morals, which I don't think it is justified, because each one who seeks for this pregnancy termination has their own reasons to terminate pregnancy. And termination of pregnancy is one situation. By providing safe abortion, we can avoid many complications of abortion. Secondly, we avoid unwanted pregnancies. And thirdly, at the same time, we have an opportunity to counsel each woman regarding further contraception. So we should not miss this opportunity, but at the same time, we have to be very, very careful in maintaining the privacy of the woman, what she wants, and do the work under the legality of the rules and regulations of termination. As we know, as Yashodhara has already said, that now second trimester abortions have gone up to 24 weeks. So we are relieved, because many times second trimester ultrasounds, congenital abnormality, malformations, all reports come late, and many times after 20 weeks, many women could not get abortion done even with the malformed fetus or other problems. So now we have that latitude of 4 weeks more where we are now comfortable, and I think things would be much better now. I don't know, all of you have read it. I recently read that in Calcutta High Court, a woman at 34 weeks was allowed termination because the baby had a neurological defect, and I think it was too late because we would not call it a termination of pregnancy, rather it would premature delivery or induction of delivery. But that would not work out because even many times such babies remain alive for some time, and it is torture for the family or everyone for that. But I'm very, very happy for this. And I'm sure that the people who have joined in, all the trainees, would know about the rules and regulations, would know about the technique, would know how the record data maintenance has to be done, and how much privacy we can maintain. It all has to be there. And out of all this thing, as a service provider, our main aim is to provide safe abortion and have as many as less unsafe abortion in the country as possible. So I wish this training program, Yashoda, Nisha, with all your trainers, a great success. I'm sure everybody is going to enjoy this, and I'm sure that the records would be available once you have this training. And if it is available, then we would like to have it in the end of the training. Thank you very much, Yashodhara and Nisha and everyone. Best of luck for everyone for this training. Thank you.
Thank you, Chandraji, for your blessings. Now I'm coming to the program. This is a 2-hour program. And the first talk is by me only, the President Locks, the laws, rules, and implications of MTP Amendment Act 2021. The second talk is going to be on the methods of safe abortion, WHO recommendation, by none other than the Secretary Locks, Dr. Nisha Singh. And the third talk, again, I'm going to cover with the WHO toolkits. And the fourth talk is going to be by Dr. Rekha, who is a joint secretary. She's a professor and she's a joint secretary of Lucknow OBGYN Society. She'll talk on pre and post abortion counseling of this program. So these are the 4 topics we are going to cover today. And pre-test already been filled. Probably once, Mr. Ajay, I'm not sure, they will also get a post-test.
Yeah, I've sent you the link just now in the chat box. I've sent it to Nisha as well.
Yeah.
Okay.
So at the end of the program, before you close,
Yeah.
can we share it in the chat box?
Sure.
People can
Yeah.
fill that in and do it. I can take a minute here.
Yes, of course, you can. You are most welcome.
Good afternoon, everyone. It's such a pleasure to be here. And a huge namaste to Chandravati for being here. And I still remember almost 18 years back when I used to come to KGMU, and you used to lead our entire program related to EMOC. And thereafter, under your leadership, we did several other programs, till your superannuation. And then the team in KGMU kept taking everything forward on the path that you set.
Thank you, Sanjay.
All that had to be taken. It's such a pleasure to see each one of you here as well. Nisha, Yashodhara, and Rekha. Yashodhara has been troubling me every day for the last 1 week. Every day in the morning, it's a very morning for me and a very, very late night for her. But she has been absolutely dedicated and committed to make sure that this program came to live and is successful. Nisha has been part of our core group, who has been taking all these initiatives apart from RAC, the Dhira program as well forward. Thank you, Nisha, for being here and taking this whole process forward with logs. And I'm happy to inform you that Lucknow Society is the first society in UP to have taken forward the RAC program as a society, and also the first society to have taken up the Dhira program in school as well. So huge congratulations to all of you for having taken this in the right earnest.
We can clap.
We can clap for us.
Everyone. As of today, there were 99 registrations, and I can see 35 are here. So I cannot, I don't think that all 60 will be in some emergency.
have-
So I'm sure they will join in, but they would be missing out an important part. And
Yes.
I don't know how the system will pick this up. And that, it will impact the certification later on. But anyway, we'll cross that bridge at that point in time. Just to also reiterate here that this is the flagship program of our beloved president, Shanta. Shanta, along with Foxy and WHO, have initiated, as pointed out earlier. And in the 70s, this program used to be called as unsafe abortion. And it took almost 30 years before it got known to be as safe abortion. And it took 50 years now in 2020 that now it's being called as respectful abortion care. And I think we are almost there and arriving there amongst a few countries across the world that something like this is actually happened for the last 50 years. And many countries that don't even have a program at this point in time and keeps struggling to offer any kind of, safe abortion services, or for that matter, a respectful abortion care services. So with that, coming to an important aspect, at the end of the session, when the program comes to the end, after Rekha delivers a last talk, both Nisha and Yashodhara will put on the chat box a link. When you click on the link, you will be taken to the post-test and feedback. Click on that link, submit the post-test and feedback so that you become eligible for completing the program and eligible for your certification. And in case you miss that out, which I don't think so you should, but when you leave the meeting, another pop-up will come. Yeah. So one is in the chat box and one is in a pop-up. So even if you by mistake leave the meeting, a pop-up will come which will ask you to continue the program. Just click on continue. Again, you'll be taken to the post-test and feedback and you can submit it. So you have two opportunities to submit this thing. And later on, do not get worried that why I didn't get it, why I did not get it. This is your requirement and you have to complete this non-negotiable to be able to complete this entire course as is required by Foxy and the donor, which is WHO. So with those words, thank you so much for having me here. And it is such a pleasure to see you, Chandravati, after so many years. And all the very best to each one of you. Have a successful.
Now you can understand, Mr. Ajay, that why I was so much troubling you, because this program without presence of Chandraji, I could not imagine.
Absolutely.
So I needed her blessing. So I was just asking about how to send her the link. You told me and I have submitted her registration, but I do not know, Chandraji, did you get the registration?
नहीं फिर से करा ली. I got it done just now. विशा ने फिर भेजा मेरे को लिंक.
अच्छा, लेकिन हमने अजय ने हमको बताया था, तो हमने अपने उससे जो है आपका रजिस्ट्रेशन करके सबमिट कर दिया था, जिससे आपको लिंक आ जाए.
जुड़ गया, हो गया सब.
Anyway,
चलो अच्छा हुआ, आज का दिन बन गया. अजय ने इतनी तारीफ कर दी तो बस आज दिन ही बन गया पूरा.
नहीं हम तारीफ की बात ही नहीं है. जो जिस चीज को डिजर्व करता है उसकी
इन दिनों तो इस उम्र में तो सब चीजें अच्छी लगती है सुन के कि अच्छा लगा, पास काम किया कुछ जिंदगी में.
No.
It's always a pleasure.
We always talk about you, and every time I come to KGMU, I've been staying in the hostel there. I don't stay in the hotel.
I know.
I have quick access, and the team has been very, very supportive all through the years that I have been coming there regularly. So with that, Yashodhara, it's back to you.
Yes.
To commence the program.
Thank you so much.
Thank
you so much. And I would, okay, I'm just finishing it out. You can say afterwards. Okay. So because there was some clarity now we have, next time we will have a flyer and the logo of President Shanta Kumari ji, because I always want that logo is really impressed me so much that I want to see it every time. So next time, probably we have got 500 members. Maybe we are going to have another meeting, and then we will be able to do because of that.
Yeah, Nisha,
So
you had to say
Nisha,
something.
now you
So
can
I was
do, and
just
then I
saying,
can start after my
yeah.
presentation. Okay.
So I was just saying, because the comment you made that yes, 99 people had registered and now it is 45. I've put in a message in our groups also, but even if some are not able to, this is what I was putting up. I've written on mail also 500 members. So we will definitely need one or more sessions for this. So we will cover up all our members to that.
Sure. Just let me know the date and time and I'll
Right.
allocate the Zoom.
Sure. Thank you.
All
That's
the
all.
best for your program. Yeah.
Thank you.
So now I can share my screen and going for the first topic. Can you see my screen?
Yes, we can see your screen.
Okay, and I'm audible?
Yes.
Okay, thank you so much. So I'm going to start. And before I start, this is a very, very important part. Medical termination of pregnancy is Amendment 2021, because I have seen that how much effort has gone into it to get all this, which was the cry was for so long for increase the age of gestational age of MTP because of the congenital malformations and all those problems. So I'm really thankful to your effort, Ajay, and our president Foxy, and previous team of the Foxy, all the teams of the Foxy who has been attached to this program, and WHO for all their effort, and the ministry to cooperate with all the things. So thank you so much for everyone. So this objective of this module is, we will take a closer look at what are the new laws and what are the changes in the rules have been done. That's an important aspect of this, because we all have read many times, but we are not able to understand. So my request is, if there's any question, you can put it in the chat box. So I'll try to do this. As I have already said, that unsafe abortion in India is a 8% maternal death despite 50 years of our MTP Act, which has been one of the leading mark for the India, for the internationally, because it is only India which has come out with this. India has taken the lead to reduce the maternal mortality, was one of the very important causes to come out with the MTP Act to remove the unsafe abortions. But still we are having the unsafe abortion, and still it is a third leading cause of the maternal mortality. And 2 out of 3 of the abortions performed are deemed unsafe. Nearly half the pregnancy-related deaths are in women, and girls are under 24 years. What a wastage of the young life. So how you can say that whether this abortion is safe or it is not safe? So if you see, if you see that there is a 3 columns are there. So if it is being done by the appropriate method and by the trained person, only then it is safe. If one of them is present, then this is less safe. If both of them are not present, it is unsafe. So these are the criteria to say whether it is a safe.
Sorry, 1 minute, Yashodhara. I think
Yeah.
some person called Sunita Mishra is doodling a lot with her marker. So therefore you see some marks on the slide. Can you avoid
Yes.
that, please, Sumita or Sunita Mishra? Yeah, carry on. Carry on. Sorry,
Yes.
Yashodhara. Can you see
Thank
those
you.
marks?
Yes, I can see the marks. Now I've seen, but I was not looking at the periphery. I was just looking at the center, but I can see now. Thank you so much, Mr. Ajay. So medical termination of pregnancy amendment 2021, safe and comprehensive care mandated by the law. So what are the salient features? So we have to see that first thing, if the previous act said the requirement of opinion of one provider for MTP up to 12 weeks. But what has changed? Requirement for option of one registered medical practitioner for termination of pregnancy up to 20 weeks. So the gestational age for with the consent of only one registered medical practitioner, it can be terminated up to 20 weeks. Requirement of the opinion of 2 providers for MTP for 12 to 20 weeks. This was the previous act. But now, after the amendment, requirement of the option of 2 RMPs are needed only when the pregnancy is beyond 20 weeks, 20 to 24 weeks of gestation. So what is the potential outcome? It will be increase in number of the facilities, especially in public sector like PSCs, eligible for service provision till 20 weeks. So till now, we did not have this facilities who are having all the resources to do the MTP till 20 weeks. So this is one of the challenge which we have to face, and it will, with the time, government will be able to do it. So the second is modification for the vulnerable group of the women. It's very important. So MTP is permissible beyond 20 weeks only when it is immediately necessary to save the life of the pregnant woman. This was in the previous act of the MTP 2003. But now, after the amendment, it is enhanced the upper gestation limit from 20 to 24 weeks for special vulnerable categories of the women, and further enhancement for the birth defects not compatible with life on medical board consensus. So this is a great change. A potential outcome is increased access for vulnerable women to safe and legal abortion services defined by the rules committee, includes violence victims, minor, among others. And I'll also come with this slide also. It is beautifully projecting which are the category of the vulnerable women. So again, there is a modification for the birth defects and congenital. So what modification has been done? The previous act said any pregnancy can only be terminated up to 20 weeks. But now the 2021 amendment says upper gestational limit does not apply in cases of pregnancies with substantial fetal anomalies diagnosed by medical board. So it can go up to any way, but it has to be after 24 weeks. It has to go to the medical board, and medical board will decide that what can be done. And there's a time limit. So it is a very, very good changes which have occurred for the providers. So what is the potential outcome? Increase in the access to safe and legal abortion services, who often seek services late beyond legal limit for termination of pregnancies with substantial fetal anomalies diagnosed late, thus reducing unsafe abortion and court cases. So this is the one which is going to reduce the individual court cases. I'm sure that now the amendment is there, the medical board will be functioning like a court, and the court pressure, the burden of the court will be reduced, and person doesn't have to run from pillar to post to the court for getting the termination of pregnancy done. So this is a very important thing. Then modification related to the marital status. The previous act said the condition of failure of contraceptive was applicable for only married women or her husband. But amendment says 2021, condition of failure of contraceptives to be extended for any woman or her partner. What is the potential outcome of this change? Increased access to the safe and legal abortion for any woman, irrespective of the marriage age, especially with upcoming changes in legal age of the marriage, an important advancement for increasing access to the safe abortion. We all know that Indian government is going to change from 18 to 21, the marriageable age. Next, the change is, previous act said the medical termination of pregnancy regulation 2003 mentioned that information should not be disclosed except under authority of the law. But now it says name and other particulars of the woman whose pregnancy has been terminated shall not be revealed except to a person authorized by any law for the time being in force. And what is going to be the potential outcome? It is going to increase in privacy, confidentiality of abortion seekers, increase demand, but need to safeguard rights and dignity of the woman and provide respectful bias-free services, including counsel and contraception. So let me be very clear, this whole program is for the providers. How they can provide all privacy, confidentiality, respect, dignity, equity, autonomy to the woman who is coming to you for any rhyme and reason. We are not bothered about it, for the safe abortion services. So law was salient, the prioritized confidentiality and safety. This is a very important thing which has come out, that confidentiality is the uppermost thing. Name and other particulars of any woman seeking abortion to be confidential except to a person authorized in any law for the time being in force. So confidentiality is a very integral part of it and a very, very important part of it. Ground of failure of contraceptive has been extended to the woman and to her partner. So rules under MTP Act also defines that what are the special or vulnerable category of the woman, and norms for the registered medical practitioners whose opinion is required for termination of pregnancy at different gestational age. Powers and functions of the medical board is also been included into it. And mainly it is OBGYN, pediatrics, radiology, or anybody who is, the state is going to make these boards. Already, I am sure that these boards are existing in the Uttar Pradesh in many districts, because of some sterilization problem came long ago, and then it came and the district board and other boards have been made. So it's a state which is going to come out and will be more clear in the future with the Ministry of Health, and with the FOXI is going to make them more clear. So what are the special category of the women who are eligible for MTP between 20 to 24 weeks? So one is survival of sexual assault, rape and incest, women with pregnancy in humanitarian settings, disaster, emergency situations as declared by the government, as it is the COVID-19, the lockdown was done, nobody could reach to anywhere. And we have seen that what has happened to these women, and we have faced many times, many problems during lockdowns. Change of the marital status during the ongoing pregnancy. This also we have witnessed, many patients we have seen, widowed or divorced. And women with physical disabilities, major disability as per criteria under the Disability Act. Mentally ill women, including mental retardation, minors, fetal malformation that has substantial risk of being incompatible with life, or if the child was born, it would suffer from such physical or mental abnormalities to be seriously handicapped. I remember that many times we used to face the anencephaly at 32 and 34 weeks, and we do not know what to do. And I've seen that because of this, many of the people we could not do the medical termination, they have gone to some small places to get this MTPs done. Thankfully, they all came out well, but they had unsafe abortions. So this MTP Amendment Act is going to be really blessings for the providers. So what is the RMP? The RMP is defined in the old act as MBBS or more with any medical practitioners assisted in 25 cases of MTP, of which at least 5 is being done independently. Medical practitioner who has completed 6 months of the house surgery in the obstetrics and gynecology. Medical practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology. Medical termination. Medical practitioner who has experience of at least 1 year in the practice of obstetrics and gynecology. So these were the only 4 people, 1 RMP for 20 weeks, 2 for 20 to 24 weeks, and medical board beyond 24 weeks of medical opinion is the latest amendment is being done. And this was the old criteria. But now what we have done, what the amendment has brought, under the amendment rules 2021, an additional category of the provider has been added for termination up to 9 weeks with medical methods. So RMP with experience in obstetrics and gynecology at any hospital who has performed 10 cases of MTP by medical method of abortion under the supervision of RMP in a hospital established or maintained or a training institute approved by his purpose by the government. So anybody who has done 10 cases of the MTPs with the medical method of termination, medical method of abortion, and has worked under the supervision of the registered medical practitioner is now allowed to do the MTP up to 9 weeks. So these are the 5 categories of the RMPs are now there. So till 9 weeks, the experience at any hospital, 3 months in the practice of obstetrics and gynecology, or has independently done 10 cases of MTP by MMA under supervision of a RMP in a hospital established or maintained or a training institute approved for this purpose of the government. I'm still getting these lines. I'm sure that Dr. Sumita Mishra, Mr. Ajay has said that please remove that. So I request you to please, Dr. Mishra, do that. Second is a practitioner who has assisted RMP in the performance of 25 cases of MTP, of which at least 5 have been done independently in a hospital. Third, a postgraduate degree of the diploma in obstetrics and gynecology. Fourth is a practitioner who has completed 6 months of the house surgery in obstetrics and gynecology. And fifth is a practitioner who has experience at any hospital for a good period of not less than 1 year in the practice of OBGYN. So these are the 5 categories of the RMPs are there, and till 9 weeks, there is only one RMP is being required, and this is a qualification of the RMP. So for the till 12 weeks, experience and training requirement for the RMP. Still, there is only one RMP is required, but now the definition changes. So it is only 4 category of the RMPs who can do this medical termination of pregnancy. A practitioner who has assisted our RMP in the performance of 25 cases of the MTP, of which at least 5 have been done independently in a hospital. A practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology. Anybody who has done 6 months of the house surgery in the department of OBGYN, or a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of OBGYN, and up to 12 weeks, only one opinion of only one RMP is required. So beyond 12 weeks till 20 weeks, the criteria of the who can do these abortions is now only 3. A practitioner who holds a postgraduate degree or diploma in OBGYN, a practitioner who has completed 6 months of house surgery in obstetrics and gynecology, a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of the OBGYN, and still up to 20 weeks, only the opinion of one RMP is required. So this has all been done because we do not have all OBGYN at the periphery hospital, and we do not want that women should run from their own places to the distant places. So this is all changes has been brought for the woman who is seeking abortion, and to increase the demand and to reduce the unsafe abortion. So because one RMP is present at any place, whether it is a primary healthcare center or whether it is a small nursing homes. Otherwise, they have to go to any place where the 2 RMPs are there. So now this amendment has brought a big change. So beyond 20 weeks till 24 weeks, experience and training of the 2 RMPs are required. And the qualification of these RMPs is going to be a practitioner who holds a postgraduate degree or diploma in OBGYN, a practitioner who has completed 6 months of house surgery in OBGYN, or a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of OBGYN. So, and beyond 24 weeks, it is a medical board who is going to decide for the termination of pregnancy. The norm for the RMP whose opinion is required is the 2 RMPs and the opinion of medical board. So the qualification of the RMP is going to be either a postgraduate diploma or degree in OBGYN, or anybody who has done 1 year of the practice in any hospital of OBGYN. And the opinion of the medical board is very, very important for the termination procedure when advised by the medical board is carried out with the safety precaution during with the appropriate counseling at any approved place, which is having the opinion of 2 RMPs. So what are the composition of the medical boards? Is a gynecologist, is must, a pediatrician, a radiologist or sonologist, but there is going to be a 1 woman member and the 1 doctor from the government hospital. Probably in the institution, the head of the department is going to be the chair of that medical board. And this is a little bit with time is going to be more clear with this. So what are going to be powers of the medical board? To allow or deny termination of pregnancy beyond 24 weeks of gestation period only after due consideration and ensuring that the procedure would be safe for women at that gestational age, and whether the fetal malformation has substantial risk of it being incompatible with life or if the child when born would suffer from such physical or mental abnormalities to be seriously handicapped. So now this power has gone to terminate the pregnancy beyond 24 weeks to the medical board, and they are going to ensure that procedure is going to be safe for the woman, and the fetus is having the substantial risk of being incompatible with life. Co-opted specialists and the board can ask if they feel that more than these three radiologists, gynecologists, they are needed. They can co-opt other specialists also in the board and ask for any additional investigation if required for deciding on the termination of pregnancy. So it is very important that one can see that how much importance to the medical board and the powers is being given. The FOXI with Minister of Guidance and WHO support as part of the respectful abortion care can optionalize and host medical board formation on the website. So this is what FOXI is going to do, and going to put all the information of the medical boards on the FOXI website. So functions of the medical boards is to examine the woman and her reports who would approach for medical termination of pregnancy, provide the opinion of medical board in Form D with regard to the termination of pregnancy or rejection of request for termination within 3 days. So there is a time limit is also there, within 3 days of receiving the request for medical termination of pregnancy, to ensure that the termination procedure, when advised by the medical board, is carried out with all the safety precautions along with the appropriate counseling within 5 days of the receipt of the request for medical termination of pregnancy. So it is within a week, all the procedures is going to be complete. The medical board is going to give the opinion and to see where it is going to be done. And within 5 days, this procedure has to be completed, the termination of pregnancy. So we have to remember that FOXI has an important role to play in ensuring there are functioning medical boards in every state as it is stated in MTP Amendment Act. So this is a registration and pre-test, post-test and feedback is important, as Mr. Ajay has said, that it is, you have to get, I'm going to put in the chat box, or the Dr. Nisha has already been put it probably. And at the end of the program, you will also get a pop-off and you have to click, do the post-test, and only then you are going to get a certificate. So thank you so much for this. And we all know that India abortion is legal. Let us mark it safe and respectful and make the Samarth Bharat the Sampoorn Bharat. Thank you so much. If there's any question, I'm there to answer it.
Question on the chat box.
There's no question in the chat box.
Please put on chat box. Any query, please come out. Okay.
अरे हम लोग को ये मिलेगा प्रिंटेड पूरा?
मंजू जी, ये तो ऑलरेडी हम लोगों के पास किसी ने डाला हुआ है हमारे ख्याल से लॉक्स 1 पे, पूरा जो वो है गैजेट ऑफ द दिस थिंग व्हिच हैज हैपेंड ऑन द October 2021.
या उमा मैडम ने डाला है.
हाँ, वही मैंने देखा था किसी ने डाला है.
अरे
मैंने सोचा कि शायद इंफॉर्मेशन नहीं है लोगों को, तो फिर हम लोग जो है वो करें. सो इफ देयर एनी, हाँ फिर से डलवा देना, फिर से डलवा देना, फिर से डलवा देना.
अरे बुढ़ापे में याद नहीं रहता ना.
अच्छा मंजू जी, आप तो क्या बताएं, मतलब you are the all blessings. Anyway, thank you so much for the patient hearing. Now I stop sharing my screen and Dr. Nisha will take the second talk. So Dr. Nisha is a professor in the Department of OBGYN and she's a secretary LOCS. So
thank you, ma'am.
Yes,
I'll just,
now you can share your screen. You can share your screen.
Share in the chat box. I'll just answer a few things they have written. Somebody has written, kindly provide pre-test. See, pre-test you did when you did the registration. So it is done. For the post-test, I will put the link after we have finished with all the sessions, not now. So this was the other question, where is the post-test? And then somebody has asked, what is the difference between practitioner and RMP here. So
Let me clear that, Nisha.
okay.
This is there's a different names are being given to different people who are having the who can do the abortion. So in India, it is the Ministry of Health has said the name is given is a registered medical practitioner. So anybody who has done the MBBS, who is on the registered in the MCI and who is having enrolled into the MCI is a eligible person, and that is a registered medical practitioners. And the things I have already cleared who is a registered practitioners, and which has been added, new one is been added, category of the registered medical practitioners to do the abortions, to do the abortions till 9 weeks, by the medical method of the abortion.
आयुष
So this is registered
आयुष
medical.
वाले
No, no,
आयुष
no.
वाले
No,
आरएमपी
नहीं,
होते हैं ना
नहीं मंजू जी, वो आरएमपी नहीं, मैंने आपको बताया ना, आरएमपी इज ए एमबीबीएस पर्सन
नहीं,
who
वो तो
has
हम लोग
registered with
समझते
the
हैं
MCI. नहीं, but this has been clarified by Dr. Sumita Ghosh from the Ministry of Health that she is a deputy commissioner, that who is going to be the
और वही लोग सबसे ज्यादा करते हैं
चलिए मंजू जी, कभी और इस पे बात करेंगे. We should continue with this
Yes, ma'am.
program. So Nisha, you can join
Yeah.
and share your screen.
So Dr. Manju, I just wanted to say कि ये rules हैं, अब जो इसके against होगा वो तो अलग चीज है, but इसको हमें follow करना है. एक मैम question, एक point और किसी ने लिखा है कि kindly provide all forms. So forms wherever the facility is there, they will be getting from the CMO office, or they will be getting these forms, not from through this training. And then in the end, please share the link below at the end. Acha, theek hai, that is yours. Fine. So I'm
Yes,
just sharing.
I just pasted because
Right.
I
Okay.
thought that you have pasted, but I did not see. So I thought that it is.
Yeah, ma'am, I'll just
Yes.
share my screen. Too much matter on my.
Yes, Dr. Shikha Srivastava has also said, because she's also associated with the family planning and all these problems, medical termination of pregnancy. So she has written BMS and BUMS are not allowed. And we also know that registered medical practitioner doesn't mean that. Manjuji, I do not know how you are confusing, but we always had that registered medical practitioner is the one who has the MBBS degree in this. Long back, this used to be other practicing people from the other branches also is being called RMP.
So, okay, I hope my slides are visible. I'll just make it full screen.
Yes, this is visible.
Yeah, so very good evening to all of you, and I'll be talking on the safe abortion updates in technology. So we have heard about the rules for the amendment in the rules. So who can do it and what are the qualifications required till what age group? Now there are not many changes, but still to update a few regarding the methods that will be used and how you have to do. I'll be talking about that. So the overview of the session is actually talking about the existing guidelines, pre-abortion assessment, medical method of abortion, and surgical method of abortion. That is what I'll try to cover. There have been these WHO global guidelines on safe abortion, and recently in 2018 we had all the guidelines for the medical management of abortion, and the surgical method also has been taken. So there is one in 2019 also, which is a comprehensive one. So if you see the WHO national publications on safe abortions from 2012, there has been some modifications. There has been a handbook in 2014. And then in 2015, there was another one where there was a role, health workers' role in providing safe abortion care and post-abortal contraception. And then the 2018 one is the main, where medical methods have been dealt with in details. And in 2019, the consolidated guidelines on self-care intervention for health. So these are the pictures of the reading material that is available online also. If you open the website, you will find these PDFs there. Now talking about the Ministry of Health and Family Welfare National Guidelines on Safe Abortion, just to recapitulate that in 2021 March, the law was changed and the rules have changed in September 2021. So it is now after these two things that we are able to utilize these rules and regulations and the new amendments and put them into practice as and where needed. So all the guidelines have three key areas in the management of abortion safely. One will be the pre-abortion care. That is, how do we evaluate the women? How do we, somebody's mic is on. Could you please mute yourselves? Okay, so the pre-abortion care is about how to assess the women, how to see who needs it, what will be the method best for them. And then we have to learn about the different methods available. And then the aftercare is also very important. Follow-up is also very important. And there is a great role of providing contraception and counseling to these women. So how do we assess the women when they come to us? We have to take a medical history in detail. There will be some important points, we'll talk about them. Then the physical examination is important. We can't ignore the general physical and the gynecological examination, the speculum and the PV examination. Then we'll talk about the laboratory investigations, what are mandatory and what are actually required only in certain cases. Then we have to discuss the contraceptive options that can be given. So after all this we have done, still the decision making will be with the woman. If the woman chooses to have an abortion, she should be allowed to choose from among the various methods that are suitable for her, appropriate for her, and based on the, of course, it will be based on the duration of her pregnancy and her medical condition. So now talking about the pre-abortion assessment for women seeking first trimester abortions. We take the detailed history, we do an examination, lab tests, and then decision making. So we'll just talk about that now. When we take the history, the most important thing is to assess the period of gestation. And also by the clinical examination, the purpose is to correlate the two. Whatever period of gestation is coming by the history, is it the same by the examination too. So we are all gynecologists. We have been assessing the size of the uterus by the bimanual pelvic examination and the abdominal examination. So we know that after 4 weeks of pregnancy, the uterus starts enlarging and gradually there is an increase in size, and we usually talk about it as 6 weeks, 8 weeks, 10 weeks, and then once it reaches the pubic symphysis, and rises out of the pelvis, it is a 12 weeks uterus. 20 weeks we know is when it reaches the umbilicus, and in between, halfway through that is 16 weeks. After 20 weeks of gestation, the fundal height in centimeters is measured from the pubic symphysis, and it approximates the weeks of gestation. This is just a revision kind, but we all follow this. Now, the limitations to dating by uterine size on physical examination, there could still be chances that there is a difference in the gestational age or the size of the fetus as compared to the physical examination that we are finding. So where will it be? It will be in cases when there are some uterine malformations or there are some fibroids, then obviously the size would be bigger than the period of gestation. When there is a multiple gestation, if it's a twin or a triplet pregnancy, of course the size will be bigger than the period of gestation. Obesity, marked uterine retroversion may make it difficult to assess the size of the uterus. Molar pregnancy size usually is more but can be smaller also. So a uterus that is smaller than expected that is on examination, the woman is not pregnant. Sometimes if it is coming smaller, maybe she is not pregnant, but she just has missed periods and actually the pregnancy is not there, or her dating is inaccurate, she doesn't remember the date properly, or the dating is correct, she is pregnant, but the pregnancy is not intrauterine, it is ectopic pregnancy or an abnormal pregnancy, like there is a missed abortion or there is some spontaneous abortion, that is an incomplete abortion also. A uterus that is larger than expected may indicate an inaccurate menstrual dating. multiple gestation, uterine abnormalities such as fibroid that we have talked about. So we have to understand that we take the history, then we do the examination and we try to correlate. If there's a discrepancy, we have to think about these things which could be the cause of that discrepancy. So now coming to the pre-abortion investigations, routine lab tests are not a prerequisite for abortion services. That is an important statement that we are making. Tests that may be performed as per individual risk factors on finding of physical examination, we'll be just talking about them. So you have to individualize which patient needs a particular investigation. Pregnancy test, if the pregnancy is confirmed, that is, if your examination finding does not suggest pregnancy. Hemoglobin or hematocrit for suspected anemia. RH testing where RH immunoglobulin is available and you will be able to give it to the RH negative women. HIV testing and counseling, if it is available, you should do that. STI screening usually performed during the pelvic examination if it is available. Other laboratory tests will be depending upon the medical history. Of course, if there is some serious medical history, kidney or liver function tests, etc., will be needed. And in those cases, mostly we will refer them to the higher centers if there are such high risk cases with us. So now the important one, or the very commonly used investigation, that is an ultrasound. There's a special bold statement about that. Ultrasound is not necessary unless to diagnose of pregnancy, not certain or suspecting ectopic or missed abortion. So whenever your clinical findings are making an indication that it could be maybe the pregnancy is completely not there, or it is suspected of ectopic or a missed abortion, that is the size is smaller or bigger, then in those cases, you should do a scan rather than routinely in all cases. It is not required there. So in the pre-abortion counseling, once you have done that, you have to ask the patient certain other important things also. Ask her thoughts about termination of pregnancy, the reason for termination. That's important because sometimes they come just under pressure of the family, the husband or anybody else. So you should be clear that the woman really wants it. Inform her that early abortion is safe. That is, lesser the period of gestation, more safe is the process of abortion. Importance of a trained provider performing the procedure for safety. What are the available methods of abortion? This we have to tell her. Risks and the warning signs that are associated with the method. So that will be a method specific counseling. And without contraception, she can get pregnant as soon as 14 days after abortion. This is very important. So in the pre-abortion counseling itself, you mentioned that, okay, once you have assessed that she needs it and we have to give it, then tell her that, see, after say about 14 days, you can actually get a pregnancy again. So you must go for it. Simultaneously plan something so that we can provide that with the abortion facility itself. Resumption of her normal activities, including sexual intercourse, when that can be advised, and any other follow-up care that is required, that will be individualized depending upon the method that you are using and the risk factor the woman has. Among the documents, we will have an informed written consent and decision to accept post-abortion contraceptive. So consent for the procedure and also the method and the decision to take up a contraception also. So even if she is not willing for contraception, she will be provided the abortion services. Now, this is important that you cannot deny giving the abortion services if she does not want to take a contraception. Though it is our responsibility to try and counsel her and make her take up something, but you cannot deny this abortion services. Probably this is a part of the respectful abortion care, that is, we have to respect her choice. Clinical management of abortion, now talking about the gestational age and the type of methods that can be used. Now, global recommendations and the Government of India recommendations, there is a slight difference. So you just pay attention to this, that in the global recommendations, less than 12 weeks and more than 12 weeks are the two categories. Less than 12 weeks we can do with mifepristone and misoprostol combination. We can do it with misoprostol alone. And we can do the surgical evacuation abortion by vacuum aspiration. While after 12 weeks, you can do by the medical methods, again, mifi plus meso alone, and then dilatation and evacuation. What is not recommended is dilatation and curettage. In contrast, the Government of India recommendation is that medical methods have to be used until 9 weeks only. That is the up to 7 weeks, that is 49 days, we are using mifepristone 200, and then after 24 to 48 hours, we are giving misoprostol. I'll just come to another slide because here they have put 800, 800 same. I'll come to the next slide, please. Okay. So medical methods are available, surgical methods are available for both are available for the first trimester abortion. So how do we, what are the medicines that we use? Mifepristone, we all know, is an antiprogestin which inhibits the action of progesterone. So it interferes with the continuation of pregnancy. So we give this tablet mifepristone initially to stop the continuation of the pregnancy. And this is followed by misoprostol, which is prostaglandin E1 analog. And this causes cervical softening, uterine contractions, and expulsion of the product. So it actually facilitates the process of expulsion. So mifepristone is interfering with the continuation of pregnancy, and misoprostol is facilitating the process of expulsion of the products of conception. So what are the protocols that we have of the mifepristone and misoprostol combination? On day 1, we give mifepristone 200 milligram tablet, which is given orally. And if the woman is Rh negative, simultaneously we give the anti-D injection 50 micrograms. This is first trimester abortion we are talking, so 50 micrograms is enough. And on day 3, we give actually misoprostol. This is a type mistake. Up to 7 weeks, we give 400 micrograms of misoprostol. The methods by which you can give by sublingual, buccal, vaginal, or oral. I'll just show what are the differences in all of them. If it is 7 to 9 weeks pregnancy, the dose of the misoprostol is doubled, that is 800 microgram. And the mode is sublingual, buccal, and vaginal. If we don't recommend oral for 7 to 9 weeks. In addition, you give some analgesic and antiemetic because of these prostaglandins, women may have vomiting. And of course, during the process of expulsion, they will have pain, and offer the contraception also. Within day 15, follow-up has to be there. Confirm and ensure completion of the procedure. Offer contraception if already has not been given. Now talking about those 4 different routes that were there, let's just clarify what do we mean by all of them. Oral, when we say the tablet is taken just like we take any oral medication, it has to be swallowed with water. This is recommended up to 7 weeks. As I said, after 7 weeks, we do not recommend the oral intake of misoprostol for the first trimester abortions. Side effects include diarrhea and nausea, fever, and chills. Second is the buccal. Pills are placed between the gums and the cheek. I'll just show you a picture also here. So this is the buccal, the first one, where it is between the gums and the cheek that you have to place. Sublingual is under the tongue. So buccal is pills placed between the gums and the cheek and swallowed after 30 minutes. Here there will be more fever and chills than vaginal route. So it will be more, the onset of action will be faster in this case. Sublingual pills are placed under the tongue and swallowed later after 30 minutes. Increased fever, chills, diarrhea, and vomiting compared to vaginal route. Fastest onset of action and highest plasma concentrations. So that's how these two have been added, the buccal and the sublingual, because of the faster action. But then we understand that the side effects are also a little more as compared to vaginal. In the vaginal procedure, vaginal route of misoprostol administration, pills are placed in the vaginal fornices in the deepest portion. So you put it on your finger, gloved finger, and put it into the posterior fornix as high as possible. And woman is instructed to lie down for 30 minutes. Pill fragments may be visible later, and there is lower rate of side effects, but the onset of action will be a little later. This I have already told. So now seeing the WHO recommendations, as I said, WHO recommendations are less than 12 and more than 12. And they say that less than 12, you give 200 milligrams of mifepristone on day 1, and after 24 to 48 hours, so that is next day or the third day, you give 800 micrograms of misoprostol, buccal, vaginal, or sublingual. And if you are giving only misoprostol, then you can give 800 micrograms of misoprostol alone. Vaginal bleeding for 2 weeks is normal after medical abortion. Such bleeding can last up to 45 days in rare cases. So that you have to counsel to the patient. But if she continues to bleed after 14 days, then definitely a follow-up visit is required. Maybe earlier, if it is too much bleeding, too much heavy bleeding, that is more than the menstrual bleeding. So provision of these medical methods of abortion services, they should be available at the primary care level with referral systems in place for all required higher level care. We talked about the high risk women, the high risk factors. So ideally it should be available at the primary care level, and those who have risk factors should be referred to the higher centers, or if they develop any complications, then they should be referred. Additional services may need to be provided to individuals seeking medical abortion, like counseling and testing for STI, abuse support services, psychological or social services, or other specialist health or medical services. They may be required, and this you will assess after you have talked to the woman, you have taken a history, you will be able to decide that which woman requires some additional services. Simultaneously, we have to provide iron tablets if she is anemic, provide any necessary pain medications, and emotional support has to continue throughout the care that you give to the women seeking abortion care. For follow-up, as we said, that usually the abortion will happen and then the bleeding will stop by 14 days. So a routine follow-up is not necessary following an uncomplicated medical abortion using mifepristone and misoprostol. A follow-up visit 7 to 14 days after the procedure may be offered to provide contraceptive counseling and services, emotional support, or address any medical concerns. So if you are using Mifi plus Miso and everything goes uncomplicated and you have given the contraceptive counseling or whatever is required has already been dealt with, it's not necessary that she returns back after 14 days. But if she has this contraceptive counseling is left, or she needs any other, she has any other issue, she can come back between 7 to 14 days for a follow-up visit. A routine follow-up visit is recommended only in cases of medical abortion using misoprostol alone to assess success of abortion. So this is all based on the fact that when we are using Mifi plus Miso, the chances of failure will be very minimal. But if you are using misoprostol, please mute yourself, all of you. So if you're using only misoprostol, then the success rate may be little less. So in those cases, a routine follow-up is recommended. During the follow-up care, you assess the woman's recovery and ask for any signs or symptoms of ongoing pregnancy. So you confirm that it is a complete abortion. Review any available medical records and referral documents. That is, if you had assessed that she will need to be sent to the higher center later, then you send her now. Ask her about symptoms experienced since the procedure. Perform a focused physical examination. Put the back
Please mute. All of you are requested to please mute, or the host if can mute all others except the person who is speaking. Can we get?
I request the back-end team to
host please mute everyone except the speaker.
Thank you, ma'am. So during the follow-up visit, ask about any symptoms that are experienced since the procedure. Perform a focused physical examination. Depending upon her complaints, you do an examination. Assess her fertility goals and need for contraceptive services if not provided earlier. So this we are repeating again and again, that right from the time she comes, you talk about it, the contraception, and ensure that by the end of it, you are able to provide her something or the other which suits her best. So to summarize about the medical methods of abortion, on the first visit, you have to do the physical and pelvic examination, confirm the eligibility that she is up to 7 weeks, because that is the Government of India guideline. Give her mifepristone 200 milligram and anti-D 50 microgram if she is an Rh negative woman. Tell her that you have to return for the misoprostol administration after 2 days. Take her contract address and the phone number, so that in case she doesn't come, you can call her, and also give her the contract address and phone number of the facility so that she can contact in case she has any emergency. Record her experience of any side effect on this medical method. Let's understand 3% women may expel completely with mifepristone alone, but misoprostol schedule has to be completed. This happens many times in clinical practice. She says she's already expelled, and then sometimes some practitioner may think that now there's no need. So please do not think like that. Give the misoprostol dose of the day 3 still to that woman. On the second day, on the second visit, which is on the third day, give misoprostol 400 micrograms, sublingual, buccal, vaginal or oral. Observe for 4 hours, give her some analgesic. Ibuprofen 400 milligram is good enough. And talk about, give the contraceptive options also, whatever suits her best. Tell her that the mean period of bleeding will be 8 to 13 days. There may be some nausea, vomiting, diarrhea, headache, fever or dizziness, and she should report in case of excessive bleeding or pain abdomen or fever, which I said bleeding more than the menstruation. And she has to report if there is no bleeding 24 hours after misoprostol also. So that is another, that means that it has not worked at all. Now, let us remember that 75% of the women will abort within 4 to 6 hours after the misoprostol administration. So it's only 25% who will be actually aborting after they have left for, during the follow-up period that is there. The third visit, which we say would be around 15th day, pelvic examination to ensure the completeness of abortion, contraception options, hormonal, condoms, IUCD or sterilization depending upon what suits her best. Tell her about immediate return of fertility, and that's why the need of contraception is there. Report back if there are no periods within 6 weeks of completion of abortion. This is also very important, that she must come back if she doesn't get her normal menstruation within 6 weeks of completion of the abortion process. So that will indicate that maybe there is continuation of the pregnancy. So ultrasound only if the examination does not confirm the completeness of procedure. So this is the summary of whatever I have talked before. Side effects and complications. We know that patients usually will have pain. We should be respectful about this, not judgmental, and we have to give verbal support, adequate counseling, and there has to be a support person with her, and tablet ibuprofen 400 milligram we have already talked about. If there is persistent pain with failure to respond to these drugs for several hours, this indicates that we need to evaluate what is the cause. Maybe we have missed an ectopic pregnancy or infection, so we should not ignore, we should not be disrespectful because she's just complaining of pain, and we should not make our wrong perceptions that it's just that her threshold is too low. So nausea and vomiting usually are self-limiting, but if required, antiemetics can be added. Diarrhea, if at all, there might be a single episode or something which will be self-limiting. Reassure her, tell her that this will just be all right. Infection should not be there if you have taken all precautions. Confirm by physical examination and start antibiotics if you see any signs of that. Action for failure or incomplete result of MMA. So if there is failure, you have to complete the abortion by vacuum aspiration, or you can repeat the MMA. Depends what the patient accepts better. So whatever best suits her, she can take that. In case of incomplete result of MMA, either you observe if the bleeding is just minimal, you can repeat the misoprostol, or you can offer the surgical method of evacuation also. This is all we have been doing. Usually we do these things, and if the heavy bleeding continues, we usually give a surgical method of abortion, and once the bleeding is resolved and uterus is normal size, we come to know that it is a complete procedure. In case of excessive bleeding PV, if the woman is presenting for more, which is more than her menstrual cycle, she's soaking 2 pads in an hour, then we have to see that whether the bleeding decreases over time or not. If it does, then it is all right, we can counsel her. But if it doesn't, then you have to do a PV examination, look for any POCs in the cervical canal and remove them digitally. After that, some of them may respond and the bleeding may stop. But if it still continues, we have to do a scan and look for decidual bits if they are present and see how much is the amount. If they are minimal, we can wait and watch. But if they are significant and a woman is stable, we can give her misoprostol. But if she is not stable, bleeding is too much, there are retained products also, then vacuum aspiration will be required. And if it is a clear-cut continuation of pregnancy, then also surgical evacuation is required. Now, talking about recording and reporting, somebody had written about the form. So let me just tell you that since MMA comes under the purview of the MTP Act, documentation will be similar to the surgical procedure. And it is mandatory to fill the 4 types of forms. Form C is the consent form, and the consent should include the procedure consent as well as the contraceptive consent if she has given for something. Form 1 will be the RMP opinion, that is your assessment and final decision making that this patient needs abortion, and this will be the method. Then there will be some monthly reporting forms to be sent to the district authorities at the centers. They are Form 2, and Form 3 is the admission register for case records that you will maintain at your facility. Now, talking about the methods of first trimester abortion, surgical methods, which are manual vacuum aspiration or electrical vacuum aspiration. So surgical abortion methods in first trimester, vacuum aspiration is considered as the best. The recommended technique of surgical abortion up to 12 weeks, actually, WHO recommends that this is the safest. Vacuum aspiration is the safest method. Procedure should not be routinely completed by sharp curettage. So instead of dilatation and curettage, we all have to switch over to vacuum aspiration, that is suction evacuation, the aspiration through either electrical machine, that is your EVA, or the manual MVA syringe that we have. So the manual vacuum aspiration, we all know that there is this syringe. I'll not go into the details. It has a handheld aspirator to generate the vacuum, and aspirator is attached to cannulae of different sizes, 4 to 12 mm in diameter. They can be used in multiple settings, including with and without electricity. So we have the IPAS cannulae usually, or the easy grip cannulae, and with weeks of gestation, example 8 weeks, 8 mm cannula for 8 weeks gestation, or 10 mm. So that's how it's easy to decide which cannula to be put in a particular woman. And electrical aspiration is with the suction machine. So everything at the patient end is the same. It's just whether you attach the syringe, the MVA syringe, or you attach the tubing of the suction machine. Now, talking about cervical priming, it may be considered for women with a pregnancy of any gestational age to prepare the cervix and make it soft and easy to dilate. The recommended methods of cervical preparation before surgical abortion. So it's in surgical abortion that we are talking about the cervical priming. We can give an oral mifepristone 200 milligram, which could be given 24 to 48 hours in advance. So that is from the OPD itself. You give her that and call her next day or day after for the evacuation. Another thing you can do is put in a 400 microgram of misoprostol sublingually 2 to 3 hours prior to the procedure. So she'll have to wait the same day for 2 to 3 hours. Same you can put in vaginally also, but here you do it after 3 hours only. Laminaria tents, if available, can be placed intracervically 6 to 24 hours prior to procedure. So let's just understand that what you use for priming and then when she will have the procedure done. So accordingly, you have to ask that whether she's willing to come again after 2 days or 1 day, or if not, then if she wants it same day, to better to use the misoprostol 400 micrograms. Pain management plan for this VA procedure. It is important component of quality abortion care, reduces the pain and anxiety and makes women comfortable. We have to use the non-pharmacological and pharmacological methods, both. Providing psychological support and explaining each step to the woman in advance, performing the procedure gently and smoothly, and encouraging her to relax and deep breathing. All these things are the non-pharmacological methods of pain management, and we must include them in our abortion care. The pharmacological pain management, we can have anxiolytics, we can have the cervical dilatation methods, and we can have analgesics. So among the anxiolytics, we can use diazepam 10 milligram orally 1 hour before the procedure, or we can give 2 to 5 milligram IV 20 minutes before the procedure. This is for surgical evacuation. Side effects would be disorientation and dizziness. So after the procedure, you will have to keep her for a few hours till she is able to walk on her own. Cervical dilatation, you can do with some lignocaine or local anesthesia. That can be, so during the cervical dilatation, the pain that happens can be reduced by giving 1% lignocaine, which has the duration of 60 to 90 minutes, and you can perform the procedure well. You can use ibuprofen 400 to 800 milligram about an hour prior to the procedure. This also works for 4 to 6 hours. And yeah, so that can be used. The side effect could be gastritis with analgesic. I think the steps of MVA need not go into much detail. Just in short, we have to prepare our instruments. That is the charging of the syringe that we have to do. And we have to then create a vacuum. That's what the charging is. Ensure the pain control, giving the medication and all the non-pharmacological methods. Tell her to pass urine and then make her lie down, and then do the cervical antiseptic preparation. Give the paracervical block, that was the 10 ml of 1% lignocaine. With that, you can give 2 and 4 or 10 and 2. 4 and 8 and 10 and 2. Dilate the cervix with the dilators or directly with the cannulas also, you can do that, and then perform the procedure. Suction of the contents, withdraw the cannula 1 to 2 centimeter. I think people have had the training of this MVA separately also. And so we keep rotating after withdrawing the cannula 1 to 2 centimeter from the fundus inside the uterine cavity. We rotate the cannula from 10 o'clock to 2 o'clock position. And because the vacuum is already there, the contents keep coming. And once it is there, then it is full. Then we release the vacuum button on the aspirator. Once we have completed, the signs would be the red or pink foam without the tissue passing through the cannula, a gritty sensation over the surface of the uterus, and the cannula is gripped by the cervix. You know, it keeps like as if the cervix is holding the cannula. Uterus is contracting around the cannula, and there is increased uterine cramping. These are the signs that the procedure is complete. So then you inspect the tissue, put it in, strain it actually, and then maybe with a gauze or a strainer, and then you ensure that the procedure is complete. Simultaneously proceed with contraception methods. If she has opted for IUCD, it can be put in soon after. Instruments have to be soaked in chlorine 0.5%, that is routine for all procedures. Assess the disinfection and help remove tissue and body fluids. Post-procedure care will be monitoring her for any complications and providing management as needed. She may leave the facility when she is stable and meets the criteria for discharge. That is, she is able to move around, she is walking, she is responding, and she is able to take something orally. Then you are able to send the woman home. Ensure that she has all necessary information and medications prior to leaving the facility. Document all outcomes of the treatment, including any adverse events also, in the facility register and the client record card also. Aftercare, of course, if there are any complications, you will have to manage that. Say there is incomplete abortion or infection with antibiotics, bleeding. We have talked about that before in the medical method also. Provision for contraceptive information and offer the contraceptive counseling and methods. Assessment of any other sexual and reproductive health needs that may require additional care. And follow-up, we have said no routine follow-up unless meso-alone regime is used. This we said before also. So for surgical, there is no follow-up routinely required. So in summary, India has made historic progress in improving access to safe abortion because it was the first country to put in the MTP Act. Not much has changed in technological update in the last decade. As providers, it is up to us to ensure the safety and quality, especially in context of the amended law. Along with safety, we also need to focus on respectful abortion services. Every client, whether in the public sector or the private sector, should get an opportunity to information, education, and she should get all the equipment with proper information on contraception and counseling. She should be equipped with proper information on contraception and counseling. So these are some of the important components to give a holistic, approach to abortion care, so that her problem is sorted and she doesn't have complications, and it's, the contraception is taken care of. So that's how we are able to give a complete care and a safe abortion. Telling you again that you have done the registration and pre-test, you will have to do a post-test and fill up the feedback form, then only you will get the certificates. Thank you so much. I'll see the questions in the chat box.
Chat box regarding this presentation. So with this, probably I can now start a second because it is a little late, our session is. So I am going to start my second talk, okay?
So I'll answer the questions there itself.
Yes, yes,
Yeah.
you can, because there's no questions are there regarding
Right.
this. So
Okay.
I could not, I did not ask, okay?
Okay, ma'am. Okay.
Yeah. Okay. So now my screen is visible. Hello.
Yes, ma'am. It's there.
The screen is not visible.
No, it's visible, ma'am. Desktop dikh raha hai, desktop.
Screen is
Yes.
visible, but the presentation is not there.
Yeah.
Okay. Now you can see the presentation.
Yeah.
Yes.
Make it full screen.
Okay, I'm going to make it. Give me a little 30 seconds time because you
Now
have
it's
to do
clear.
everything yourself. Okay.
Yeah.
So thank you so much, Dr. Shyama, for reminding me this.
Thank
So
you
coming
very
to the second talk, it is all in the chat box. There's so many comments about the RMPs. So when I have done my first talk, I have already cleared what are the guidelines for the RMPs from the Amendment Act. So from my side, there is no confusion. Still, if anybody is having this thing, we can write for the clearance again for on these concerned points. So these services, I am going to say thank you to all the participants and to my seniors who have joined, my colleagues. Oimala is there. I can see Preeti is there. I can see many more people. I cannot take the name of everybody. So these are welcome because you have taken out the precious time from your routine. So thank you so much for joining this. So my second talk is on the safe abortion WHO toolkit, which describes SAVER, that is a safe abortion, values, evidence, right, and respect. So it is a respectful abortion care with the FOXI and WHO initiative. And this is the program which has been launched in January 22. And I'm so happy to know that Dr. Ajay has said that LOGS is the Lucknow OBGYN Society is the first society who is conducting this program in whole of the UP. So this is really a proud moment for us. So this module of the respectful WHO toolkit on the respectful abortion care aims to define respectful abortion care by the WHO standards, highlight how norms and stigma affect the services, provide WHO saver resources for respectful abortion care. So we know that momentum has already been created, whatever the OBGYNs were asking for change, for the amendments in the law, MTP law, It is already been done. Law has changed. Dissemination needs association and OBGYN provider support. So all of us have to now follow whatever the laws is in the MTP Act 2021. Foxy is the largest provider base for the abortion care because 38,000 practitioners, Foxians are there. So it is all Foxy which is doing all this. Online training is possible. We are all doing this online. We always used to do offline trainings. It used to be something, but now you can see you save so much of time. There's no time to be used in the commutation and stuck in the crowd and other things. So this is very nice that COVID has given us 2 online training facilities. Medical method of abortion, uptake is increased. Early, safe, ensure no PCP-NDT conflation. So we have to understand the earlier it has been done, the abortions are earlier it has been done, medical termination of pregnancy, earlier it has been done, it will have no PCP-NDT conflation. It ensures, because if it has been done up to 12 weeks, we all know that there is no PCP-NDT conflation is there. So we always want that it should be done earlier because it is the most safe procedure in the earlier gestational age. But if anyhow it is being not done, then we have to follow what are the guidelines for 12 to 20 weeks and 20 to 24 weeks and beyond 24 weeks. Patient safety, respect, and quality matters more than ever, and we have a role to play. So all providers have a role to play. So what is respectful abortion care about WHO standards? It is, I have already said, as WHO is already running a program of respectful maternity care. So it is just an extension of this, the respectful abortion care. So it refers to the safety, dignity, confidentiality, and ensures freedom from harm and mistreatment, informed choice, and continuous support during and after all types of the abortion is needed from the providers to all their clients who are coming to them for the need of termination of pregnancy. So what is respectful abortion care? In the simpler terms, you can say, as a provider or as a patient, treat and are treated with dignity, empathy, compassion, regardless of your race, ethnicity, gender, socioeconomic status, or reproductive history, pregnancies, miscarriages, or abortion. So we have to be very respectful because this is the only thing which is going to increase the demand of the center, and the women would like to come again and again to those centers who are dealing with these respectful maternity care. So if any time you feel that something is not right, you can speak up. But as a health professional, we all have always have seen that the client can say, and we have to listen, and we still have to support. So communication is the key to the success for the respectful maternity care, not only for this, for any situation in the medical profession, communication is the key. We all have learned about this. So what are the norms and stigmas for this? So I'm going to play a video to say that what are the norms and the stigmas are there in the respectful abortion care. So
social norms are the unwritten rules
can you
of
see that?
behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and or culture in which they are found. People's behavior may also change accordingly. What are some examples of
कहाँ से
social
आया?
norms? In times of COVID-19,
अरे
there
वो
are
तो
new
समझ गए
social
गुजरात का होता है मतलब कौन लाया?
Please mute everybody.
behaviors
Host, please
like
mute everybody.
wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink,
उनको
boys.
लाके देने के लिए
This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life, and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects, and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others, personally and professionally.
Okay, so now we can go to these are the norms and the stigmas were there.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to
Oh,
the
sorry.
environment.
I think completed, ma'am.
Yes, I know.
Time is running short.
Yes, yeah. Rekha,
Yes,
it was
ma'am.
8 minutes video. It was not my video, it was a WHO video, and this I have to show.
Yeah.
Okay, well, I am not taking any more time. I have finished my first talk in less than the time allotted to me. So these are the stigma and norms that perpetuate disrespect and abuse. So these are the categories which have been mentioned, that it is not only physical abuse, slapping, intimidating physically. So right of the every woman is freedom from all harm and ill treatment. Verbal abuse, as we have seen in this also, we should not use the words, we should not use the non-consented care, we should not shout or scream, because this is a right to information protection under laws of MTP and POXO, informed consent and refusal, and respect for choices and preferences, dignity and quality of care. So these are the stigma and discrimination saver video, which I am going to display after this. These are the 3, 5, 6, and 7 points are being taken from the respectful maternity care, that failure to meet professional standards of the care, poor rapport between women and providers, health system, condition, and constraint. So this is the right time, right to timely health care and to the highest attainable level of health, liberty, autonomy, self-determination, and freedom from coercion. So this is what we should not talk anything, any words which are going to interfere with the respectful maternity care, which normally under the pressure, we have seen that people are sometimes are using these words. So what are the domains of the respectful abortion care? Is 12, they are 12, is being free from the harm and mistreatment, maintaining privacy and confidentiality, preserving women's dignity, respecting women's choices, engaging with effective communication skills, softer skills, providing information and seeking informed consent, ensuring continuous access to the support, enhancing quality of physical environment and resources, providing equitable abortion care, availability of competent and motivated providers, provision of contraception advice and commodity security, continuity of care and counseling. These are the 12 domains of the respectful abortion care, and all the providers have to see that all 12 domains have to be covered. And this is, I said that this is also a part of respectful maternal care. So it is adapted from the respectful maternity care by the WHO. These all 12 domains are also there in that. So this is the time to strengthen the implementation. Whatever is being now given to by the in the amendment of the laws, we have to strengthen these services. So important changes which has been brought by this: every patient is an opportunity for respect and provider. Onus is on to us, on to educate and also reduce the sex selective abortion. This is very, very important thing. And one provider responsibility. When it is up to 20 weeks, there is only one provider, and the responsibility increases because only that person has to do the counseling, contraception, referral, and compassionate care. When you are expanding the gestational age, especially in the young people, survivors, unmarried, everyone, we have already discussed what is the vulnerable category of the women and need to overcome our own biases. We should not say whether you are married, unmarried, whether you are why you are having the abortion, why you did not use contraception. These all things we should not discuss, we should not say. We do the things for what patient has come, and with the full confidentiality, privacy, and dignity. So 20 to 24 weeks, special cases, needs for sensitivity and judgment-free advice, judgment-free care. Many of the times we have seen this. Why you have not come earlier? We have seen and we have listened. This is all not intentional. This is all under pressure. Now we have to, after this, we have to be very, very careful. Maybe we are under pressure, but we are not allowed to use these words. So prioritize confidentiality and safety. We all know the respect begets respect. As provider, we need to be mindful of socioeconomic aspect, and need and other particulars of the woman seeking abortion should not be disclosed to any other person except who is authorized by the law. And the ground for failure of contraceptive has been extended to the woman and her partner. So respect quality and dignity to all types of the abortion, whosoever is coming to you. And this is the language which we should not use.
How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world.
So this is the
Let's look
website.
at
You can go and see it.
stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or registered medical practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix side denotes killing, which is not appropriate when describing abortion. When referring to sex selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision, and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome, which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion
It's
due to the
6:15.
occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro life implies that those who support legal abortion access are anti life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the three P's provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex selective abortion is illegal. Provider and place need to be safe, trained, and certified.
So this ends, and we go, this guideline is very well is been saying that provider has to be ensure the safety, dignity, and privacy, confidentiality to a woman, and should not use any word which are stigmatized. So these are the things which we have to follow in the next whatever we are going to, when the implementation, dissemination of this act we are going to do. There are many more videos are there, but I found that this is the only one which is important. So this is a third one which I am going to fast forward.
And evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO SAVA, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO SAVA toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. SAVA has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. SAVOR is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
So this ends this video here. So we are just going to end my talk with, I am sure that all these videos must have been very helpful in understanding how to use your words, what you can say, what you cannot say, what is the right of the woman, and what are the situations which can lead to the demand of the abortion. So we should not go into the details of it. We should do a safe abortion. We should provide, all providers should provide a safe abortion services without stigmatizing, using the stigmatizing words. So this is just a recap what you have already seen into a pre-test. These questions, according to the World Health Organization, restricting, assess, reduce the number of unsafe abortion, true or false. So you can write it in your chat box, yes or no. I can see that, and then we'll come back whether it was it. So it is what is in the chat box. Anybody can see in the chat box, because I am not getting the chat box into this slideshow.
Yeah, ma'am, I'll see that. Okay.
Yeah, it is true or false, whatever the people have written.
False, 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 false.
Yes, thank you. So it is false. Only these three things has to be there. So the MTP amendment 2021 requires a minor less than 18 years to obtain written consent from parents and guardians before she can undergo termination pregnancy. Is it true or false? Nisha,
So now
please
please
check.
answer for the next question. Yeah, I'm waiting for responses.
So to cut short the time, I can say that this
Yeah.
is false. You do not require a consent from the parents or guardian. Any person who is more than 18 years of age can give a consent for this minor to terminate the pregnancy. But remember, POXO reporting is very, very important. So you provide the MTP care, but you have to report according to the POXO requirement. So another question you have to write in the chat box, yes or no. A 30-year-old woman, recently widowed, wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. It is yes or no. So again, to cut short the time, because I did not get any answers, so it is
No,
no.
they have written no. Yeah.
Okay, thank you so much. So my job has been done. All videos were very clear to everybody, and this is going to complete. So my talk has been completed with this, that the providers are going to use this Amendment Act very carefully. We are going to follow, and we are going to follow all the WHO SAVOR kits, which is which is having the what our providers' duty is to do, and what are the providers' responsibilities to do. So thank you so much. Is there any questions in the chat box?
No, ma'am.
No.
No questions.
So I stop sharing my screen, and now I invite Dr. Rekha to deliver the last talk of the session. Yes, Rekha, you can share your screen.
Yes, ma'am. So thank you so much, ma'am. And how much time I have?
You have to complete your thing.
Yeah.
Okay.
As fast as you can, as fast as you can.
Yeah. Okay. So
Rekha, make it full screen, please.
I make it full screen. This is not.
No.
Just go down on the left hand side, you will see a cup, and you can do that.
Left hand side. Where? Okay.
Lower, lower
Maybe in
bottom
your
you-
this thing different,
Yeah,
because
yeah,
it is
in-
a Mac, it is on the left. Maybe it
Mhm.
is on the right or other computers,
Where is full
other
screen?
laptops.
Here it is, Rekha.
Yeah,
Lower down right.
right in our, this is upside.
Okay, so
Mhm. This is the, now it is
no,
full screen.
no.
I am doing this, but why it is?
You have to go to this place. Rekha, can you see that?
No, ma'am. Mm. Where it
There's
Just
is?
a
try
three
to do
column.
it again.
And it's,
It's open.
you can share it again, and then you may be able to see it.
That will show here.
आप शेयर करिए दोबारा से करिए सर
Stop sharing. Okay, I am sharing again.
Thank you.
Okay.
जी
Yes.
सर पूछिए कौन सा
Slide is visible.
Yeah.
Yes.
Now it is full screen.
No, madam.
No, it
Madam,
is not.
go
It's
and
still
click
a
on the
full screen.
slideshow
Here.
tab. There's a tab at the top. Slideshow. Home, insert, design, animation, and slideshow.
This is this one is pause here. No, new share. Okay. No.
Rekha, where this is
tab,
the
madam.
green is coming, the view options is also coming. You drop down the box, and there is a full screen.
This one is it was also.
चलो अच्छे से visible है.
Madam, you just
Slides.
click on.
I can do it for you, Rekha, if you want. I've got these slides.
Of course, Nisha, you do it.
Okay,
please.
you can do this if it is not.
So
full.
please stop
Because,
sharing. I will.
Yes, it will save time.
Okay.
Have you stopped sharing?
Yeah.
Okay. I'm just doing.
It's not good.
आ गया?
Okay. Yeah. It is visible full screen, ma'am. Hello.
Is it visible to
yeah.
everybody?
Yes, it is visible. It is full screen.
Okay.
Thank you so much, Melissa.
Okay.
So, very good evening, and I'm running short of time, but I fulfill my job. That is, any abortion is not complete without family planning counseling. If we are not giving family planning counseling, that means we are not justifying with my jobs. So please, everyone should do at least family planning counseling after the abortion. Next, please. I think family planning counseling is very, very important aspect of after every MTP. And so what is counseling? We know counseling is a two-way communication. Not only we say and a person is listening for my view. So it is a structured interaction in which a person voluntarily receives emotional support. One component is structured interaction in which a person voluntarily receives emotional support. And second one is guidance from a trained person. That is very important. Guidance from a trained person. Third one is in an environment that is conducive to open sharing of thoughts, feeling, and perception. Because most of the time we are busy in OPD and we are giving counseling. This is not good. So environment should be conducive to open sharing of thoughts and feelings and perception. Next, please. Why it is important? Pre-abortion, as we listened previously, follow-up is not as such necessary, but counseling, all three phases, pre, peri, and post-abortion, all three phase counseling is required, because sometimes lady is not ready in pre-abortion phase, then it might listen in peri-abortion phase or might listen in post-abortion phase, even in follow-up. So we should take every step, every area cover counseling for family planning. It is an integral part of comprehensive abortion services. We all know without this, comprehensive abortion service is not fulfilled. As important as the procedure, jitna procedure, utna hi counseling. Without counseling, no, and without family planning, patient again get conceived, and then there is a problem. And again there is abortion. So women may need help in decision making. This is very important. By the counseling, women may need help in decision making. So we should counsel. Initially, we say this is a gather approach, greet, ask, help. So we should help in decision making. And wherever needed, the spouse should also be counseled. Sometimes we counsel, but husband saying no, and the mother-in-law saying no. So you should counsel if required, along with the client. Next, please. So pre-procedure counseling, in various places there is help. That means we should help the woman to decide about termination of pregnancy first, because there is confusion in mind. Woman itself feeling guilty and confused. So we should help in deciding about termination of pregnancy. Then we help to choose the method of termination. This is right of the woman. We should say that type of methods available, that just for that gestation is, and you should choose whatever method you like, we should do. And ensure delivery of the complete information about the procedure. This is very, very important. Most of the time we are in hurry, we say half and half left. Then this create mess. So we should ensure complete information about the procedure and help the woman to adopt a contraceptive method. It is very important, because if we are helpful, so she listen us, and if patient listen us, then they follow our advice. Next, please. So it is very important to ensure privacy and confidentiality. Since the beginning, we are saying ensure privacy and confidentiality. It is very, very important. With this Amendment Act, it is very important. Otherwise, it is punishable even up to extent. And be non-judgmental and be sensitive. Non-judgmental. Most of the time we say loose talks, but don't do this. And you should not be judgmental. We should non-judgmental and be sensitive and establish rapport. Rapport is very important. If patient and doctor's rapport is good, then there's no chaos. And use simple language and allow the woman to clarify her doubts. If we are talking in English and she is Hindi, then let's understand Hindi, then there is a problem. So you should use simple language. And if she has made up her mind for termination of her pregnancy, assess her. Don't say no, this is very wrong and pregnancy termination not good. Always you say yes. If she is willing for termination, you do this. She adopt contraceptive method, opt or not opt, no problem. You should give the services of abortion, termination of abortion. Next, please. Next. So this is opportune time for contraceptive acceptance, because lady is listening you and you have made rapport with her. So this is very important time to tell about the contraceptive method, and she is very much accepted at that time. So you should tell there is quick return of fertility. This is very important issue. Within 10 days, might be you say, ma'am, we come after 15 days, 14 days, but at that time might be you get pregnant. So quick return of fertility is very important issue with the abortion. And minimum 6-month gaps before the next pregnancy is also, as per WHO norms, is very important to fulfill the requirements of the body. Health benefits and better future pregnancy outcome. Contraceptive is very, very important. 90% of abortion-related maternal mortality can be prevented by ensuring the contraception. So contraception is very, very important, and you should avoid repeated abortion by family planning counseling. Next, please. So what is pre-abortion family planning counseling? When to start? I said it starts since beginning, first visit consultation. Sometimes there is some ladies worried and but what to counsel? Importance of return to fertility. It is very important. Return to fertility within 10 days to 4 weeks. Please unmute, and it helps with choices. You help the woman with choices, and counseling should be method specific counseling. If women opt any method, then you should give method specific counseling. And if any high risk behavior, then you should talk about that. And you should give in addition to condom or something else. If the woman is not willing for any contraceptive method, do not refuse MTP. This is very, very important point. If woman is not willing for any contraceptive method, do not refuse MTP. Most of the time we force, please take opt contraception, but you should not refuse. You should counsel, counsel, counsel. Whenever she is ready, you give that. Try and counsel her after the procedure. If she is still not willing, call her for follow-up in a week. As such, follow-up is not required, but for the family planning counseling purpose, we should call her for follow-up in a week time and counsel again for the family planning methods. Next, please. Assessing suitability for post-abortion contraception. What are the rules? Abortion process is complete if you are giving contraception. Then you should ensure abortion process is complete. And if you are using copper T, this is very, very important. No existing infection. Otherwise, this may flare with the copper T insertion. And no injury to genital organs. And chances of fresh pregnancy should be ruled out. If lady is returning after 14 days or 21 days, then chances of fresh pregnancy should be ruled out. Next, please. Post-procedure counseling is also very important. If she is not ready in pre-abortion counseling, then we should counsel post-procedure. Ensure women have understood precaution and care needed during post-abortion period. This is very important because if we are not giving advice, then there may be some problem. Opportunity to counsel for contraception in cases not previously accepted. This is very important and very good time to counsel for contraception if she is not accepted previously, and reinforces the need for continuing use of contraceptive method chosen. It is very important. Sometimes patient woman is ready for the contraception, but later on she left away. So you should reinforce the need for continuing the use of contraceptive method, whatever she has chosen. Next, please. So post-procedure counseling include continue, reassure, repeat. What continue? Continue to ensure privacy and confidentiality. It is very, very important. Every woman wants this privacy and confidentiality, and reassure her in case of any problem. If you should say, I am with you, with good rapport, I will help you if any problem, then this reassurance is very, very important. And repeat the information about post-procedure care and danger side. You should again repeat the information. Otherwise, she might miss it. Initially, she is in tension and she is in anxiety, so she might forget. So you should repeat the information about post-procedure care and danger sign like bleeding, pain, foul smelling, discharge, and fever. You should always tell about all these danger signs. Next, please. So post-abortion family planning counseling include all, if already opted, appreciate. Always appreciate the woman. Most of the time we forget. So we should appreciate. She has opted our national program, and immediate care if required. You should give immediate. If she needs intrauterine device, you should insert. She willing for the injectables, you should give. Ongoing oral pills, if she's taking oral pills already previously and somehow she left, this can be continued. Follow-up protocols should be tell the woman. And continuity is very important. And provide the card. We are giving at the time of discharge, we are giving the card in showing the insertion of IUCD or taking the injections, all written in the card. And undecided, if she has undecided till time, then allay her anxiety and tell importance of immediate contraception, whatever she chosen. In extended period of adoption, you should tell, no problem, you can come in next time you can choose this. In couple counseling, if sometimes there is a spouse creating a problem, then couple counseling is important, and emergency contraception pills should be discussed. Next, please. Various methods available. We all know barrier methods, pills, and injectables, in IUCDs. So many methods available, and every method used at different times. Barrier method, there's no problem. As soon as, even first trimester abortion or second trimester, whatever the time of abortion, gestation is for the abortion, you should advise to use as soon as you start their sexual activity, because it can be used anytime. And additional benefit with that, no hormonal side effect, can be used without any health provider, easily available at every place. In government sector, it is free. In prevention, it prevents against STI and HIV as well, enables men to take responsibility of contraception. So it can be given when there is start of sexual activity. So no problem with the condom. Next, please. Another one is intrauterine devices, intrauterine contraceptive devices. These are very important, long-acting, reversible contraception. This is very important point for this. In two types of devices available. One is IUCD 380A and another is IUCD 375. IUCD 380A working for 10 years and IUCD 375 for 5 years. So these IUCDs can be inserted immediately after the surgical abortion, or up to 12 days after the abortion. And whatever the gestation is, immediately or up to 12 days in first trimester abortion as well as in second trimester abortion. But you should ensure procedure is complete. You should ensure there is no infection. But with medical method of abortion, these IUCD inserted only 15th day of the process and after the confirmation of completion of abortion and no any product of conception present. So these IUCDs are highly effective, provide long-term contraception, and can be provided by trained provider. This is very, very important. Trained provider only provide this. In first trimester, it can be given by even A&M nurses, but in second trimester, only trained doctor, MBBS, and trained doctor only give this, insert these IUCDs. With the MMA also, there is trained person, because trained persons should rule out infections. And no interference with the sex. In good is immediate return of fertility. Whenever you remove the IUCD, there is the immediate return of fertility. No hormonal side effects with the IUCD. So it is very good contraceptive method. Next, please. Another one is hormonal contraceptive pills, combined oral contraceptive pills. One thing is important, you should not give the women who are breastfeeding in baby less than 6 months old. Otherwise, we can give immediately whenever procedure complete or up to 7 days after abortion using surgical method in first trimester as well as in second trimester abortion, in both same condition. And with medical method of abortion, you can give on third day, day 3. Whenever you give misoprostol to the woman, you can give the simultaneously COC. But if left or you forget or woman is not willing, then you can give on day 15 of the process after confirmation of completion of abortion. This is very important. And additional benefit with this COC are regulate menstrual cycle. Post-abortal AUB is quite common, so it regulate menstrual cycle, can be provided by all health workers after first screen. After first screening only by the doctor. After that, any trained provider, A&M, ASA, can give this COC. No interference with sex, offer protection against ectopic pregnancy, endometrial and ovarian carcinoma, and even benign breast diseases, fibroadenomatosis, fibrocystic disease, but it is not suitable for breastfeeding women. Next, please. Another one is injectables, hormonal contraceptive. Like initially we said this is DIMPA, depot medroxyprogesterone acetate. Now we say it is antar between two child. That is medroxyprogesterone acetate. And it can be used in first trimester, in second trimester, both type of abortion, immediately after the completion of abortion or up to 7 days after abortion, just like COC. And if the medical method of abortion, it can be given on day 3. When you are giving misoprostol, you can inject this medroxyprogesterone acetate. It is highly effective, confidentiality and privacy maintained because no one knows. and can be provided by doctors first time, and later on any trained person can give this injection. And no interference with sex, no effect on the quality and quantity of breast milk, no estrogenic side effect. This is advantage. Offer protection against ectopic pregnancy, ovarian cancer, in even because it causes amenorrhea. So iron deficiency anemia get corrected, in even in uterine fibroid, bleeding reduced, and return of fertility takes within 7 to 10 months after the stoppage of the injection. Next, please. Another one is permanent method. Everyone knows permanent method, that is female tubectomy, male vasectomy. In tubectomy is two type mini lap, that is open in is with a small incision. In lap, that is lap ligation with a laparoscopic method. So in first trimester, we can go for both, either mini lap or laparoscopic, both possible. In these both, but we should be sure that there's no infection and there's no severe blood loss during the abortion procedure. And it can be used concurrently or up to 7 days. Sterilization can be done with, if medical method of abortion, then it can be done only after the first menstrual cycle. This is very important. This is the only method which we use only after the first menstrual cycle in medical method of abortion. Mini lap sterilization can be performed with the second trimester abortion, but laparoscopy usually, because uterus is growing out of the pelvis, so chances of perforation and chances of complication during pneumothorax is more. So laparoscopic sterilization usually we avoid in second trimester abortion, but mini lap, we can do mini lap in concurrently, we can do along with the procedure or up to 7 days after an abortion, in the absence of any infection. This is very important, in the absence of any infection or severe blood loss. Benefit and additional advantages are permanent method of contraception. You should always tell this is permanent method of contraception. Though we reverse this, but it is not, we should always tell this is permanent method of contraception. Highly effective, effective immediately, no interference with the sex, no effect on the breastfeeding, no long-term side effect, offers protection against ovarian cancer. So we can go for the female sterilization. And another is vasectomy. Vasectomy has, vasectomy means we cut the vas deferens in male. This is male ligation. And this not dependent on the timing of the abortion or procedure of the abortion. It can be, a male can go for this type of vasectomy anytime, any trimester of pregnancy or any trimester of abortion. And it is very effective permanent method of contraception, no interference with his sex, no long-term health risk. Couple must use another contraceptive method for at least 3 months because the sperm are present in the semen. So at least use 3 months another method of contraception along with that. So in nutshell, we can say COC, the combined oral contraceptives, injectables, that is methotrexate acetate, and centroman. These all use on day 3 of the abortion. Whenever you give the misoprostol, along with that, you give these drugs for the contraception if lady has been counseled well and she is accepting for that. Next, please. Next.
You can, yeah. I'll just
One more slide is here.
Yeah, IUCD on day 15.
Yeah, IUCD we can use till the, ideally it is day 12. It is indicated for the day 12. But I think in the next slide. In ligation is especially up to day 7. This is the slide. COC can be given up to day 7, immediately, or day 3 or up to 7. Injectables can be given immediately or day 3 or day 7, up to 7. In centroman also can be given up to day 7. IUCD can be given up to 12th day of the abortion, day 12 of the abortion.
This is with the surgical methods.
This is with the surgical method. After vacuum aspiration, in ligation can be done up to 7 days after the surgical abortion. Otherwise, interval ligation after that. Next, please. Various sexual and reproductive health services are available in that is teleconsultation and other technology available. In these technology basically developed might be in the because of shortage of manpower as such, and because of this COVID era. Next, please. Improve the knowledge, various technology has developed that is to provide the service, that is teleconsultation, telecounseling, teleguidance, telereference, telelinkage, and we do telemedicine also in the COVID era. In the various other techno IC available, that is website, Hamdo, in social media, Astanu, YouTube. On YouTube, you can see all these things. These are beautiful pictures are visible there. Infographic. In
Rekha, if possible, you can wind up, Anna.
Okay, ma'am.
Because we have done the important
slides. Two more slides.
We have done all important slides.
Yeah, this is what teleconsultation. That is what is the strength of teleconsultation. That is in COVID era we use this in approachable throughout the process and person confident in awareness is spread by this method in COVID era also. In the weakness are that face-to-face communication or conversation not possible with the teleconsultation. In demonstration is also not possible with that. In opportunity is that it provides privacy, in comfort, in cost saving, in no number of visits cut down with this teleconsultation. In the threat are that we missed opportunity and sometimes we misdiagnose the patient on the telecommunication. In applicability of the components of CAC, that is comprehensive abortion care, that is assessment, confirm diagnosis. For the assessment, it is very important to confirm diagnosis in contraceptive needs. In counsel by video conferencing or Zoom, and follow either by hybrid services or by one visit or medical method of abortion for the 3 visits. So key messages for this main talk is that realize the need of post-abortion family planning counseling and bring the couples on the board and strive for the 100% coverage. This is very, very important, and capitalize on the basket and applicability in the post-abortion period. Technology as far as possible, scope for entry in CAC services, comprehensive person care services, and concern is policy, malpractices, service cost, and adolescent reproductive health needs both online and offline. We can give the patient women, adolescent girls. Next, please. So this all, if any question,
already been done.
Put on the chat box, and you should go for this post test, and you should not discontinue. If you discontinue, then this will not applicable. So you should continue in do this post test.
Okay. So can we ask everyone to on their video?
Yes, ma'am.
Yes, all participants who are there, they can
put on your
video,
videos,
so we
please.
can-
We'll take one picture for records.
Yeah.
गुड मॉर्निंग यशोधरा जी।
गुड मॉर्निंग, क्या हाल है?
बस ठीक है।
शिखा,
Good morning, ma'am.
गुड मॉर्निंग, गुड
Dr.
मॉर्निंग
Manju
एवरीवन।
Shukla, could you please put your video on, ma'am?
मंजू जी दिख रही है भाई, मंजू जी दिख रही है, मंजू जी का वीडियो ऑन है।
अरे
मंजू जी
यार
कैसे
तो
दिख रही है?
सुनते सुनते थक गई।
मैम के पास 2 हैं, 2 कनेक्शन है।
यशोधरा जी का गुड मॉर्निंग हो रहा है।
अरे भाई ठीक है, क्या करें, जिम्मेदारी है, सभी जिम्मेदारियां निभानी पड़ती है ना, चाहे वो
मैम ले ले क्या, अभी ले ले।
While we are getting ready for the photographs, I just saw one comment which I couldn't help but respond to. Anima Prasad is writing that already completed the post.
Yes.
So I don't know if the session is not over, and I'm praying that you complete it after completion of Rekha's talk.
But how?
Please mute everybody so we can listen to Mr.
Anima, can you reply, please? I hope you completed after Rekha's
ma'am.
Because if you have not done that, operationally we will have a lot of trouble at the back end.
स्ट्रेस हमें नहीं डालना है।
हाँ
जी जी सर, इससे ज्यादा स्ट्रेस हमें नहीं डालना। और सर
हेलो
क्या
No,
डॉक्टर अनिमा?
I'm asking Anima.
Yeah, ma'am has shared the link and I completed.
Before the session ended.
No.
After second session, module, I completed my thing.
Very good. Congratulations. Now, please do not come back to me for the certificate because it's not in my hand. The back-end system is set up in such a way I have no control on it. The moment it will match the time, that the timing of the session was 4 to 6, and you have submitted very smartly your post-test at 5 p.m., it is not going to issue the certificate. Now tell me, what will I do?
Then I have to go for it again.
Yes, you have to go to the POP and
No, you don't
submit
have
it.
to go to the, I really don't know, because the system has already recorded your post-test before
Yeah.
completion of the program. You
Yeah.
tell me, what will you do in my place?
I give the certificate. If your candidate is okay, you should give.
They should get that certificate. And would you teach that to your children also? If everything is okay, you should pass in everything, and therefore you should get your certificate.
Please give
Sorry to
link.
say this, but you cannot be so lackluster about it.
Nisha,
Yeah,
link
just a
दे
minute.
दो भाई.
Ma'am, 1 minute. No, but Anima, we did not share. Madam, did you share it here?
Yes, I did share it because I wanted them to realize, because it has already been said at the end of it, you have to submit it.
No,
नहीं
but
तो
we
दिया
had to
क्यों
share
link?
it.
It was not written there. It was shared and we filled it.
Yeah.
Because
But
some people were
Mr.
asking and I was repeatedly.
AJ is
अच्छा
clearly
भैया हम तो
explaining
भर नहीं रहे हैं. सर्टिफिकेट देना और
that
दे
they
ना दे दो.
In any case, we don't need it.
मैम हम करें क्या पोस्ट टेस्ट का कहाँ है लिंक?
ये तो
Just a
देखो,
second.
तुम्हारे पास अभी जब खत्म
दिखा?
होगा करोगी, तुम्हारे पास
दिखा?
एक पॉपअप आएगा, कंटिन्यू, तो तुम उसको कंटिन्यू करोगी, तुम्हारे पास पोस्ट टेस्ट आ जाएगा ड्रॉप बॉक्स में, तुम उसको कंप्लीट करके सबमिट कर देना बस. और
Mr. Ajay, please. Mr. Ajay, please.
Please do not misunderstand me. I and we are as Foxy bound by a certain norm of the funder and the donor. It's not in my hand. The system has been set by them, and they record everything according to what is the system setup. Now in back end, I can't go and change anything. You understand? I can't go and change anything. Whatever is recorded there.
That's all right, sir. It does not matter.
Okay, so you try, Anima, once again to submit it at the, now, because the session is ended. I hope the system recognizes as a duplicate and allows it to pass through.
Okay, sir, I'll try.
चलो
Yes,
देव
sir, I shared the
भाई.
link in the chat group also, sir.
अरे
Chat box.
Yes, the link is there in the chat box also.
Yes, sir, I shared the link.
आ गया.
हाँ मैम, उसमें डाल दिया है उन्होंने, आप उससे कर सकते हैं. So and after we finish, in case you don't do it with this, then you will have that pop-up also. So you can do it
भाई
through
ये
that.
तो खुली चैट बॉक्स में दिख ही नहीं रहा.
Chat box में last जो
वो
मैसेज
ज्यादा
है
आसान
उसमें
है,
एक
मंजू
लिंक
जी,
है
वो
मैम.
ज्यादा आसान है. जो जब आप बंद करेंगी वहां पे जो आपके मेल पे पॉपअप आएगा वो ज्यादा आसान है.
इसको
मेल पर
बंद
नहीं
कर.
आएगा मैम, यहीं पर आएगा. जब आप लीव करेंगे कंटिन्यू का मैसेज.
अभी वही तो कह रहे हैं, जब लीव करेंगे मीटिंग, यही दिस इज व्हाट आई हैव सेड.
अरे यार हमको इतना ये सब आता नहीं है, तुम लोग हमको सताते रहते हो. अब हम रख दे.
मैम चैट बॉक्स में देखिए एक लिंक है, उसको क्लिक कर लीजिए. ठीक है. Okay, so
there are two options.
Mr. Ajay, any concluding remarks you
No,
want to
nothing. Absolutely. I think, sorry, I missed the session for a little while. I was in the other session, which was happening in Bijapur. But fantastically done. Excellent job done. And I was delighted with your participation and the entire bit. It's absolutely, truly an honor to be here and once again being associated with the logs and taking this entire process forward. So hats off to all of you, Yashodhara, Nisha, and Rekha. And please do continue this good work and carry forward this process with more such trainings going forward. And we are absolutely supportive to make sure you do get your Zoom slots as and when you request for it.
Thank you, Dr. Ajay. It was first meeting, so it took little longer because everybody has to take little time, and then probably next meeting it will end in time. So everybody
we are
knows
not worried on the
what to
time.
talk, what not to talk.
We are not worried on the time because the quality of interaction and the question answer session should be such that each and everyone in the program are able to benefit out of it.
Thank you so much.
I want
So,
to say that
I'm sure
on
that
behalf of-
everybody must have been knows what is a respectful abortion care and what provider is supposed to do, because it is on the onus lies on the provider. So this is very important. Now we have to one who has to do this.
So on behalf of Logs, I thank Foxy, I thank Mr. Ajay and our president, Dr. Yashodhara, and all the members who have participated in this program. And I know, as Madam said, it was the first time, so getting the links and communication and all, it was really a great effort actually for us. But next time it will be smooth, and this small hitch that happened and whatever, maybe people are just getting used to it. So we will try to confirm that it doesn't happen again, because it should be in the end, definitely. So thank you all so much for joining in. And I think we have completed, the messages that had to go have gone, and all of you can do the post test now.
Ma'am, can I ask? Ma'am,
Yeah.
can I ask one question?
Yes,
Ma'am, as I have missed a part of the session, so should I take the post test today, or maybe we'll be having another session soon?
Mr. AJ, you can.
You missed which session, ma'am? Sonia?
In between, I had to see my patient, so I missed a few important things, I think. So if the session is going to happen
See,
soon,
what I
then
would-
I'll do the post test after that session.
Yeah,
That
see,
would be
what I
better.
would suggest is there is 3 sessions coming up on 25th. There are 2 sessions, and on 26th there is 1 session. Okay, not of logs, but of some other, National Society or some other society. Your president and your secretary already have a copy of the mail with those links. You take it from them and you join in for that session only which you have missed. You don't have to attend the full session.
But what about the post test? I should attend it
And
today?
at the end of that session also, you will get a post test link, or you can use this link, save it somewhere, and use this link and submit it.
Okay, so I'll do post test that after that session, and I'll use the same link, and then only I'll get the certificate, no?
Yeah, because this will get allocated to Lucknow, this link. So use this link, attend that session. The system will check on the background, that Sonia has attended. So from here, Sonia has attended from there. It will match the system. It will match the documentation, what the donor wants. It will match all of that, and automatically the certificate will come to you. Is it clear?
Right. Thank you.
So as everybody has understood, things are not all on our hand. It's all technical problems are there. So one has to be very, very careful in using these things. So Mr. AJ, very, very thank you.
Pleasure.
To you for joining and for also answering, clarifying the questions of the participants, because this is very essential. We are not aware of all the parts of this, especially the technical part. So it is.
No, we are there to support. We are completely there to support. Nisha knows us since December now, since we have been working on this whole program, and she's been part and parcel of it. I know there are teething problems, and we are there to completely support.
Yes,
complete help.
I know you have sent me the Dhira also, but I just wrote that not this month. Next month I will be your core team. Not this month. I wrote to you.
No worries. We are there to support you.
Okay, then. So we leave. We make a leave here.
Thank you, Anima, for completing.
Dr. Anima has completed. Dr. Anima has completed. Congratulations, Anima.
You're reminding me, Anima, of one of the school students, session that we are conducting in Dhira.
Very dedicated student.
Okay, no problem.
Anima is always great. Anima is always great. Okay. Thank you.
Okay, then. Bye-bye, everyone.
Bye-bye. Have a nice evening.
Bye, everyone. Bye,
Thank you, Nisha. Thank you,
See you in the next.
Thank you all.
Thank you, Mr. AJ.
Thank you so much. Thank you.
See you in the next meeting.
Thank you, ma'am.
Vimala, thank you. And all, Dr. Akhilesh, thank you. Shikha, thank you. And Dr. Satish having some problem, thank you. There's so many people who are there. They had some problem, but everybody could join, and all my colleagues, friends, and the senior people. Nidhi is also there.
Wonderful.
Yeah.
You have explained everything so nicely. Thank you so much.
Thank you, Shama. And Sujata, Nidhi, Seema, Lavanya, everybody was there. So those who could not join, they can join the Foxy program, which is happening on 25th and 26th of this thing. Okay. Or we can join the next program when Lox is going to have. Thank you so much.
Ma'am, please do share the link with us of those future programs on 25th, 26th.
Okay, it is already there. Somebody has put it. So there was a little bit of confusion. And I said that please. But now we are going to put it. We wanted to put it after the 21st program. But some confusions, they are all part of the parcel. So
no, ma'am, the link of the 26th and 25th sessions.
Yeah, that is what I'm saying. It is already been posted by somebody of the member, but we wanted to post it after this program, so there should not be any confusion. Many people have, because there is a registration protocol. So you have to, there many dates are there. You have to click which date you want to join. So many people have joined because Foxy training is going separately from the society trainings.
Okay.
There are two. Previously, the Foxy decided that they will do only the few master trainers from the societies.
Right,
and then those will do this. But probably there's something is this, now they have extended their program to the all society members also. So they are doing final program they must have written on 25th and 26th.
Right.
So thank you, everyone.
Thank you so much.
Any questions, you can come back to any time, no problem. Okay, because this was a very important amendment of Act of MTP 2021. And it needs very responsible behavior of all the providers. Thank you.